The subcommittee will come to order. A quorum is present. Without objection, the chair is authorized to declare a recess at any time. The committee procedures for remote hearings remain the same. If you are experiencing connectivity issues, please make sure you or your staff contact our designated technical support so those issues can be resolved immediately. If you wish to have a document inserted into the record, please ask for unanimous consent and have your staff email the document to veteransaffairs.hearings@mail.house.gov. Without objection, members will be recognized in order of seniority for questioning witnesses today. This will make it easier for me to ensure all members participating in person and remotely have an opportunity to be recognized. Does any member have a question about the procedures for this hearing? Hearing none, we will proceed. And I will now recognize myself for an opening statement. Good morning, and thank you all for joining us for today's hearing, which will examine opportunities to improve VA's healthcare infrastructure and operational efficiency through public and private partnerships. Chairwoman Brownlee was unable to preside today, so I agreed to lead this hearing in her absence on a topic that's of great interest to me. VA provides world-class healthcare to our nation's veterans, to whom we owe a great debt. While we are improving care and services all the time, one of the biggest challenges facing the VA system is its aging infrastructure. On average, VA-owned buildings are more than 50 years old. The cost to immediately finish outstanding construction projects and needed maintenance would be tens of billions of dollars. It's clear to me that to address VA's construction and infrastructure needs, we will need to work together to find creative solutions. As with any large bureaucracy, it can sometimes be difficult to do something new in government. Having worked in the executive branch myself, I know all too well the impulse to come in and do the same thing that was done the day before. But VA is no stranger to finding creative solutions to complex problems. I look forward to highlighting some of those examples today and finding ways to do more of that in the future. The challenge of modernizing VA facilities is one that my constituents know all too well. VA's North Texas healthcare system serves more than 184,000 veterans. It is the sixth fastest growing region within VA's healthcare system. Unfortunately, the needs of veterans in my district have outgrown the capacity of the Dallas VA Medical Center, a more than 80-year-old building that is bursting at its seams and, because of its location, difficult for many veterans in my district to access. Space constraints at the Dallas VA Medical Center have led to greater outsourcing of veterans care to community providers, and VA has not been able to hire additional clinicians because it does not have the space to accommodate them. On any given day, the North Texas VA healthcare system sends more than 200 veterans to community providers for inpatient care. Veterans in my community have at times experienced wait times of up to 40 days for VA primary care appointments. It was clear that something had to be done to relieve the pressure on the North Texas VA healthcare system. And just over 2 years ago, with bipartisan collaboration between stakeholders at every level of government, we were able to accomplish something that others might have thought unthinkable. A vacant but still usable medical facility in Garland, Texas, was donated outright by Baylor Scott & White to the VA. The donation included 34 acres of land, a 415,000 square foot hospital, a medical office building, and a storage facility. The Garland VA Medical Center opened to patients in April 2020. Initially, it was set up to provide COVID overflow beds for the Dallas VA Medical Center, and it stood ready to support civilian hospitals should the need have arisen. Since then, the facility has gradually ramped up operations and is now delivering primary care, laboratory services, nutrition counseling, social work, and women's health. It also provides space for VA clinicians to deliver care via telehealth. By some estimates, it would have cost more than $800 million for VA to construct a similarly equipped facility in Garland, but we were able to get this facility fully activated with just $20 million investment by the American taxpayers. I think that's a pretty good deal. At its full capacity, the Garland VA Medical Center will serve more than 34,000 veterans living within a 30-minute drive and create more than 5,000 jobs in North Texas. I want to be very clear that I absolutely believe these kinds of innovative partnerships and acquisitions can help VA adequately provide health care to our nation's veterans. We should be looking for ways to expand these opportunities, and I strongly encourage VA to let us know what additional authorities it needs to make deals like this possible. Of course, the process to acquire the Garland VA Medical Center was not without its challenges. I also hope to discuss some of those challenges with our VA witnesses today and how Congress and VA can work together towards similar opportunities. We will also hear from the Government Accountability Office, which has evaluated 2 other innovative models for addressing VA's infrastructure needs, the Chip-In for Veterans pilot and the Level Federal Health Care Center in North Chicago, Illinois. The Chip-In for Veterans legislation was championed and passed into law by the late Congressman from Nebraska, Brad Ashford, who was a dedicated statesman and a great advocate for veterans. Because of his work, the Chip-In for Veterans pilot program has allowed VA to use already appropriated construction funds to partner with non-VA donors to finance, design, or construct facilities to suit VA's needs. GAO found that the very first Chip-In project, an ambulatory care center in Omaha, Nebraska, resulted in time and cost savings compared to typical VA construction projects. GAO has also evaluated the integration of VA and DoD operations at the Level Federal Health Care Center. This facility is the only one of its kind and serves veterans, active duty service members, retirees, and dependents. It was established in 2010 to test whether a jointly operated facility would be more accessible and less expensive than operating separate VA and DoD facilities in the same area. And finally, we will hear from Mr. Patrick Murray of the Veterans of Foreign Wars. Mr. Murray and his VSO colleagues have long advocated for VA and congressional action to address the ever-increasing backlog of facility maintenance and construction projects. They view underfunding, inadequate VA construction management, and unwieldy congressional oversight procedures as obstacles to timely facility modernization. Of course, we have to acknowledge the elephant in the room today, the forthcoming Asset and Infrastructure Review, or AIR Commission process, which was mandated by the VA Mission Act passed in 2018. Secretary McDonough recently released more than 1,500 recommendations for the AIR Commission to consider once it is appointed. Among them are 45 recommendations for VA medical centers to establish, quote, strategic collaborations or partnerships with entities such as DoD, the Indian Health Service, academic affiliates, or community providers to expand capacity to serve veterans. While VA is still years away from implementing any of these recommendations, if they are ultimately accepted by the AIR Commission and Congress, it is nevertheless important for stakeholders to consider now the potential benefits and risks of VA's proposed partnerships. Today's hearing will provide an opportunity to learn from past experiences and discuss best practices that could be applied to future projects. In closing, I look forward to today's conversation, and with that, I would love to recognize Ranking Member General Bergman for any opening remarks that he may wish to make.
Thank you, Acting Chairman Allred. It's nice to be with all of you this morning and to see the smiling faces in the room. I'm really, again, I probably say this at every one of these subcommittee hearings as we transition back to a sense of normalcy where people interact with people, members of Congress, staff, those of you who come to testify. We are, as human beings, social animals in a very positive sense, and we need that not only to get business done, but we need it for, I believe, just in a positive mental health standpoint, because, again, as Acting Chairman Allred and I were discussing beforehand, the value of teamwork, the value of being teammates, and in some cases, in fact, we didn't talk about this, but playing against competing teams at some times, and then being on an all-star team and playing together. I mean, that's the essence of whether it's us here as members of Congress, the VA professional staff, the Veterans Administration. That's where we're going to get the success for the veterans who have chosen to serve our country and put themselves at risk. And now it's our job to mitigate that risk wherever we can. So with that, I'm very much looking forward to discussing the vital role that partnerships play in addressing the challenges facing the VA healthcare system and impeding access to the timely, high-quality care that veterans need and certainly deserve. The VA healthcare system is the largest healthcare system in the country, and its physical footprint reflects that. But as large as VA may be, VA cannot be everywhere, that veterans need it to be, or those veterans who have chosen to live rural or remote or in just parts of the country. It is what it is. That is why the partnerships that VA has with the private sector, with academic affiliates, and with other government agencies, they're also important. Partnerships are essential to the way that VA delivers care to veterans and an integral part of the VA healthcare system. VA's community care networks are one crucial partnership that allow veterans to have greater control over their healthcare decisions and greater access to care. Again, VA's community care networks. I am, however, concerned about how VA's community care program is currently working, and I've asked Chairwoman Brownlee to schedule a hearing to discuss those concerns. I believe that hearing will happen sometime later this summer. Today, however, we are here to discuss partnerships that allow VA to address infrastructure issues. And VA has numerous infrastructure issues that need to be addressed. Example, the average VA medical facility was constructed in 1963. Needless to say, we don't build hospitals or deliver health care today the way we did back in 1963. And the good news is patients are much better off because we have made the advances in the delivery of the health care. The median age of a VA medical facility is 58 years. That is 47 years older than the median age of a private sector hospital in our country. Veterans deserve better. The status quo of using the same old authorities, same old budget process, and same old VA investment or capital investment planning efforts are not coming close to meeting the tremendous need for VA medical facility modernization and realignment. That is why Congress acted in 2018 to pass the Asset and Infrastructure Review, or AIR Act. VA's recommendations to the AIR Commission, which, by the way, the Commission is awaiting Senate confirmation, call for 62 new partnerships across the country, from New Hampshire to Alaska. Those partnerships would take many forms depending on the unique needs of the individual markets in which they would exist. This morning, we will hear more about some of the innovative ways VA is already partnering with local communities to address infrastructure issues. I am eager to see how those current efforts are working and how they will inform VA's future efforts through the AIR process. I know that some veterans and the VA staff and some senators and members of Congress as well are worried about the recommendation that VA is making to close or realign certain facilities. I know that there are some valid concerns about the market assessments that VA used to make those recommendations. That is why the work that is going to be done by the AIR Commission is key to the AIR process. Their job is to validate the recommendations that VA has made and the data VA used to make those recommendations. Their job is also to hear from local veterans and community leaders and make different recommendations if VA happened to just make the wrong call. I urge my Senate colleagues to confirm the commission as soon as possible so they can get working. It would be, in my mind, a dereliction of duty and a massive failure for veterans not to. So please, Senate, get the commission confirmed. With that, I thank our witnesses for being here, and I yield back.
Well, thank you, General Bergman, and I echo everything you just said. We will now welcome our panel of witnesses. First, we have Dr. Michael Brennan, who is the Executive Director of VA's Office of Construction and Facility Management. He is accompanied by Mr. Robert P. McDivitt, Director of Vision 23, the VA Midwest Healthcare Network. Next, we will hear from Dr. Katina Latham, who is an Acting Director with GAO's Physical Infrastructure Team. And finally, we will hear from Mr. Patrick Murray, Director of the National Legislative Service with the Veterans of Foreign Wars. Thank you all so much for being here. Dr. Brennan, you are recognized for 5 minutes to present VA's testimony.
Thank you, Chairman Allred. Good afternoon, Chairman Allred, Ranking Member Bergman, and distinguished members of the subcommittee. Thank you for the opportunity to testify today and discuss the innovative approaches VA uses to address its physical infrastructure needs. I'm sorry I'm not there in person today. Today I'm joining you from Atlanta. I am here to attend a graduation for a close friend and family member who's a veteran. We served together in Iraq. We did multiple tours in Afghanistan. He has received care and benefits and services from the VA, and today he will celebrate at the mid-stage of life earning his bachelor's degree, and I will attend his graduation immediately following this meeting. I am accompanied today by Mr. Robert P. McGibbett, Director of Veterans Integrated Service Network, Vision number 23, from the Veterans Health Administration. We are very happy to be here testifying along with the GAO colleagues, and as a combat veteran and life member myself, it's good to see VFW's participation as well. The VA has a single approach to innovation and resolving problems. It is to ask ourselves, what is best for veterans? The result of asking that question over and over and over again will cement VA as the primary world-class integrator and coordinator of veterans health care for generations to come. VA is committed to build and maintain a healthcare network with the right facilities in the right places to provide the right care for veterans in every part of the country, making sure that our facilities are where the veterans are. We ask this question of ourselves while conducting market assessments, and the VA envisions changes in markets across the country. But we are staying in every market. Between outpatient care, strategic collaborations, and referrals to communities, we will continue to deliver timely access to world-class care to our veterans in every corner of the country. VA will balance between direct care and community care, and in places where there are changes, we will be shifting towards new infrastructure or different infrastructures that account for how healthcare has changed, that matches the needs of the market, that strengthens our research and education mission, and that most of all ensures that the veterans who live in that location will have access to world-class care that they need when and where they need it. We are using all the tools and authority provided by the department to fulfill this goal. The VA builds infrastructure in many ways. We self-execute and we partner with the U.S. Army Corps of Engineers and with the General Services Administration under Title 38, Section 8103 and 8104, are general authorities for the VA's major construction and leasing. We partner with academic affiliates under Title 38, Section 8153, that authorizes the VA to share healthcare resources. We accept donations from third parties under Title 38, Section 8301 authorities. And most recently, we utilize the communities helping invest through property and improvements needed for Veterans Act of 2016 authority, more commonly referred to as CHIPN. CHIPN in 2016 established a 5-year program where up to 5 private entities could submit proposals for healthcare-related capital projects. During this initial period, 2 projects were accepted. The CHIPN legislation was extended in 2021 for an additional 5 years through 2026. Additional constraints in the CHIPN program limit the selection of projects to those that align with the VA's capital investment processes. The VA's first CHIPN project in Omaha, Nebraska was successfully completed in 2020 with the opening of a new ambulatory care center. The second CHIPN project in Tulsa, Oklahoma is a different, larger, and more complex project type than that initial pilot in Omaha. The Tulsa project will alter an existing structure to create a 58-bed inpatient hospital slated for completion in 2024. While we have the authorities just mentioned, new strategic collaborations to include much broader private or public partnerships than we currently have authority would require additional consideration. For example, VA currently has limited authority to share space with private partners, but we do not have the authority for joint development. Once the Air Commission develops final recommendations receiving presidential approval and congressional consideration, VA will need to engage with potential partners to evaluate and negotiate the nature of any newly proposed strategic collaboration. As important to leveraging this partnership, we must also use those as a guiding light to improve our own major construction process, where we should be able to achieve the same outcomes that we seek these partnerships. And we are already making efforts underway to do that in our current program. With renewed strategy, we're addressing the front end project development processes. And an example is in El Paso, which we are using a pilot. The FY23 budget, we seek to fully fund a project from our initial concept to working towards an award in 23 in less than 2 years. In the past, these processes could take up to a decade. We are making a difference now, and we are learning from our private partnerships and endeavoring to meet, match, and do as well as we can to these partnerships. Thank you for the opportunity to provide information on how the VA is innovating in infrastructure. My colleague and I are happy to respond to any questions you may have. Thank you.
Thank you, Dr. Brennan. Next, we will hear from Dr. Katina Latham of GAO. You are recognized for 5 minutes. Microphone, please.
Thank you. Good morning. Chairman Allred, Ranking Member Bergman, and members of the subcommittee. Thank you for the opportunity today to talk about the Department of Veterans Affairs partnership approaches. VA provides critical health services to about 9 million veterans and has pressing infrastructure demands, as you have discussed. VA estimates fulfilling all its priority infrastructure projects would cost about $63 to $76 billion as of fiscal year 2021. My testimony today will focus on our previous reports on 2 approaches VA has used to leverage partnerships to help address its capital investment needs. First, accepting real property donations from non-federal entities known as CHIP-in. And second, integrating VA and DoD healthcare facilities in North Chicago. First, as we reported in 2018 and 2020, under the CHIP-in program, VA has 1 real property donation in Omaha, Nebraska, as Dr. Brennan mentioned, and a second facility in Tulsa, Oklahoma, that is expected to open in 2025. According to VA officials and a donor group for the Omaha project, the CHIP-in approach and use of private sector practices resulted in project efficiencies, as Chairman Allred mentioned. For example, the Omaha project used private sector construction standards with VA construction standards, resulting in both cost and time savings compared to a typical VA construction project. In addition, the Omaha Donor Group introduced VA to an electronic design review process that was more efficient and allowed shorter time frames for each round of review. In 2018, we made 3 recommendations for the use of leading practices for the pilot program, and in 2020, we made 2 recommendations on the lessons learned for the process. VA concurred with and implemented all of our recommendations. We also reported several considerations relevant to seeking partnerships through CHIP-in model, including the challenge of the size of the donations required, the limited number of communities and donors with the ability to lead a CHIP-in project, and VA's lack of experience in recruiting donors. VA conducts assessments of its capacity to deliver health care to veterans through available VA and non-VA health care resources in different geographic areas. Earlier this year, we reported that these market assessments and associate recommendations, which discuss alternatives such as public-private partnerships, could help VA as it considers future CHIP-in partners. In another approach, VA partnered with DoD in a demonstration project integrating their medical facilities in North Chicago into the Captain James A. Lovell Federal Healthcare Center. The project was intended to serve as a national model of the joint delivery of health care and provide information on decision makers on the approach. VA and DoD conducted assessments of 12 areas of integration of the Lovell Center, such as governance, workforce, and facility operations. Neither agency's assessment of the integration found that sharing facilities provided significant benefits over a more common joint venture approach, in which the departments would share medical facility space, but would manage their operations with separate governance, staff, and budgets. In our 2017 report, we recommended that VA and DoD collaborate to conduct cost-effective analysis of the Lovell Center. They concurred with and implemented our recommendation, completing their analysis of the Lovell Center in June of 2018. The departments have continued to update the cost-effectiveness metrics through fiscal year 2021, but it remains unclear the extent to which the Lovell Center has achieved the original goals of reducing cost. In conclusion, VA may be able to leverage partnerships to address its long-standing capital infrastructure needs, but is likely to face challenges in doing so. Lessons learned from the chip-in donation partnerships and the Lovell Center integration may help provide insights as to whether these approaches can or should be scaled and their potential for benefiting veterans and other taxpayers. Chairman Allred, Ranking Member Bergman, and members of the subcommittee, this concludes my statement. I'm happy to answer any questions you may have.
Great. Thank you, Dr. Latham. And last but not least, we will hear from Mr. Patrick Murray, VFW. You are now recognized for 5 minutes.
Chairman Allred, Ranking Member Bergman, members of the subcommittee, on behalf of the men and women of the VFW and its auxiliary, I'd like to thank you for the opportunity to provide our remarks on this important issue today. We're pleased to see VA will direct funds from the Recurring Expenses Transformational Fund toward its construction accounts. But while this is a good step, we believe it only shows the lack of a sufficient amount in the original budget request. VA's construction budget should be, at a minimum, 3% of its overall operating budget, just to keep up with the growing backlog. To reduce the backlog, in addition to a higher budget request, more employees and contractors would be needed to oversee the resulting workload. Neither VA's Office of Construction and Facilities Management, or CFM, nor individual VA facilities have the manpower to plan or oversee VA's infrastructure at the levels that would be needed to reduce the backlog. Traditionally, when the VFW testifies to our Congress about staffing, we discuss the tens of thousands of shortages of medical providers. That is an incredibly important topic, considering the reports about VA staffing often cite severe shortages in critical medical fields. However, I'd like to use this opportunity to discuss specifically the hundreds of unfilled facility management positions. These often overlooked staffing shortages could provide immediate remedy for some of VA's infrastructure problems. CFM has approximately 32% vacancies at VA central office and throughout the VA system of facilities. An entity that has even higher vacancies is the Seismic Program, which currently has an 86% vacancy rate since being established in 2019. These positions are critical for VA to eventually eliminate the infrastructure backlog, and every effort needs to be made to fill these jobs. In a May 2020 report to Congress, VA described the challenges of hiring and retaining CFM personnel. There needs to be changes to the hiring authority to make these positions more competitive, not only with the private sector, but with other government agencies as well. There's no way VA can hire and retain high-quality employees if it is at a disadvantage in terms of salary. Additionally, the VFW recommends many of these positions be given the approval for direct hire authority, treated as hard-to-recruit positions. Without changing the way VA hires and retains personnel, the construction and facilities management will continue to operate at a disadvantage, and there will be even less of a chance to reduce the tens of billions of dollars in infrastructure backlog that exists today. Partnerships at VA are incredibly important. The VFW believes Congress must eliminate the sunset date on the CHIP-In program. CHIP-In is not an everyday solution to VA infrastructure issues, but whenever an opportunity arises to accept donated facilities, VA must be able to accept any facility at any value if it is in VA's best interest. In August 2020, a group of donors working in consultation with VA completed the first facility under the pilot program in Omaha, Nebraska. In April 2021, VA North Texas Healthcare System announced it would acquire a newly donated hospital. The donation of these facilities will save the VA system hundreds of millions of dollars, with estimates to build the new hospital alone exceeding $800 million. The VA Medical Center in Aurora, Colorado was finally completed in 2018 after being delayed over a decade and costing millions of dollars over the original cost estimate. Part of the reason this project was finally brought back on track was the inclusion of the Army Corps of Engineers to oversee the completion of the project. The Army Corps should be utilized more to help offset the workload for VA construction. The VFW recommends partnering with the Army Corps whenever possible to help reduce the construction backlog. VA must also continue to leverage its partnerships with medical programs across the United States. VA has some level of partnership with almost 90% of U.S. medical schools, and more than 70% of all practicing physicians trained at VA facilities at some point in time. At certain locations, there are resource sharing agreements of facilities and staff between VA and partner medical schools. We urge VA to leverage these relationships to identify more instances where shared facilities can help offset the costs to both VA and the medical schools in order for both entities to gain from this decades-long proven relationship. Chairman Allred, Ranking Member Bergman, thank you for the opportunity to discuss this important topic today. This concludes my testimony, and I'm prepared to answer any questions you may have.
Well, thank you, Mr. Murray. I will now recognize myself for 5 minutes of questions. I'll begin with Dr. Brennan. I'm proud that we were ultimately able to facilitate the donation of the Garland VA Medical Center, but the process was not without its challenges. For me, one of the most significant challenges to overcome was a lack of imagination and outside-of-the-box thinking among some VA leaders. Can you help us understand some of the initial concerns about feasibility or legality that had to be overcome, and whether clearer statutory authority would help create a smoother process should VA ever find itself on the receiving end of another medical facility donation?
Thank you, Chairman Aldred, for that question. The workings of that transfer started prior to my arrival. When I arrived at the VA in November 2019, it was well underway, and I became aware of some of the challenges. I think some of the challenges that were caused were just the factual state of some subleasing agreements that had to be worked out to aid in the transfer of the property. Also was the challenge of keeping any capital investments required to convert it to the VA's mission below the capital investment threshold, which would have then triggered more processing requirements to make it a major construction capital real estate transaction. VHA was able to take the facility on and do the necessary renovations under $20 million, and that was really a threshold we created to enable that transaction to be completed. Statutorily, I'm not sure. I think the right authorities are maybe in place. I think there may have been some hesitation because it was a different transaction that some folks may have had concerns with for the age of the facility. As you mentioned earlier, the age of our facilities in the VA is approaching 60 years. And although the Garland facility is much younger than the other VA Medical Center there, it's still a facility that will require substantial sustainment and life cycle management as it reaches the end of its life cycle. Ultimately, leadership made the decision that it was necessary to accept this property in the best interest of the VA to fill a gap in an immediate mission requirement to provide capacity and care and benefits in the new facility that we were not able to provide through our due course major construction programs. And some of that is a challenge that I'm trying to fix, where leadership will have confidence that it will not take 10 years to build a facility solution. In the meantime, we will look at these donations as absolutely the right mechanism to fill those gaps, to provide, as I stated earlier, the right care in the right place at the right time for our nation's veterans.
Well, thank you. In your written testimony, you mentioned the VA's authority to accept donations under Title 38 of the U.S. Code, Section 8301, a statute that was enacted in 1958. It's my understanding that that's the authority that ultimately allowed the VA to accept the donation of the medical facility in Garland. Do you know of any other medical facility donations that VA has accepted under this 1958 law?
Chairman Allred, we have accepted other donations, and without the actual package in front of me to confirm that it was the same authority, I tend to believe it was. But we could take a question for it and come back to you with the fact. We have accepted other properties.
Well, okay.
Technicality.
Yeah, please get back to us with that. And also, can you either answer now or respond later as to what you think could be done to increase the use of this authority?
I believe the use of this authority in relation to all the other current authorities that we have is giving our leadership and the secretary all the information to make a good business case. Ultimately, that was the decision that was made for Garland. I think we could probably do a better idea laying out the options and feeding that decision authority within the department.
Sure, okay. Mr. McDivitt, as the director of a large VISN that covers many states, I'm sure that you have observed the growing trend of hospital consolidation and closures of private sector facilities, especially in rural areas. These closures not only affect the availability of healthcare for civilians, but to the extent that VA also lacks a presence in a given location, veterans' access to healthcare is diminished overall. As a VISN director, are you actively looking for opportunities to develop new and creative partnerships to maintain or increase patients' access to care in these communities? And have you done any analysis to determine whether any recently shuttered or vacant private sector facilities exist in areas where veterans' access to care is already limited?
Yes, thank you for that question, Chairman Allred. I'm Rob McDivitt. I'm the director of Vision 23 based in Minneapolis, Minnesota, and we oversee healthcare operations in Nebraska, Iowa, Minnesota, North and South Dakota, so have a lot of rural territory in our network as well. In terms of your question, we recently entered into a partnership with Common Spirit Health, at that time CHI, to move into their Midlands Medical Center in Papillion, Nebraska. We are essentially leasing a floor for them. It was a competitive lease, not done under the chip-in legislation, that will allow us for the first time to provide VA community living care services, nursing home services to veterans in eastern Nebraska. Previously, veterans had to travel across the state for VA nursing home services. That partnership was awarded in about a year and a half. The construction has been completed. We have renovated the space and will move in on June 1st. We're also partnering with Common Spirit for services such as respiratory therapy, housekeeping, security, and a couple of other clinical services. So in answer to your question, Congressman, yes, we are constantly looking for opportunities to enhance care and access for veterans in our vision.
Well, thank you, Mr. McDivitt, and I will now recognize Ms. Miller Meeks for 5 minutes.
Thank you, Mr. Chair, and thank you, Ranking Member Bergman, and thank you to all of our witnesses who provide testimony today. So as a physician and a 24-year military veteran, I've had the opportunity to be, first having gone to medical school at the University of Texas and did work at the VA hospital that was there in their collaboration process, and then did my residency at the University of Iowa, which used both VA facilities, both in Iowa City and Des Moines, and then was on faculty in the Department of Ophthalmology at the University of Iowa, also again working in this collaborative process where medical schools are associated and integrated with the VA medical facilities there. So this certainly is a very important and timely process. And Mr. Murray, I want to also thank you for your comments about the VA's role in hiring, the hiring process and the retention of medical providers. I can tell you that after I left as the director of the Department of Public Health, applied for a job at the VA, and it took so long to even hear back. And as a veteran, and I'm supposed to have veterans preference, it took so long to hear back that by that time I had had numerous other job offers. So as a physician or healthcare provider in demand, that hiring and retention process absolutely needs to be updated, and it needs to be much more speedy. So with that, Mr. Murray, there are concerns about the data that the VA used to make recommendations to the Air Commission, since some of that data was collected during the pandemic. And do you share those concerns, and would the VFW support extending the timeline to allow VA additional time to verify the reliability of the market assessment data?
Ma'am, thank you for that question. And I guess let me answer that in two parts. Concerned about the data? I don't know. We're still going through it right now. We want to verify. I can't say right now that it's completely accurate, but we do want to make sure it is. the part about extending, we believe that the Air Commission needs the full amount of time that it was originally set up for. If this is done in any kind of half-baked manner, no one's going to accept it. It has to be given the full time to do the reviews, the recommendations, and provide transparent and accurate assessments in order for this to be accepted. It seems to be the only one thing that we hear about conclusively in Washington, D.C., that everybody doesn't like the Air Commission. But we do want to make sure that it is accurate information so we can stand by that, put our hands on it, and say, this is valid.
To that end, Dr. Brennan, what would you say to those who fear that the data the VA used to make recommendations to the Air Commission is faulty because it was collected during the pandemic? And does the VA have any current plans to update or refine the market assessments to verify them?
Thank you for that question, Congressman. There was a lot of data to collect during that analysis, and all of that data is available on the VA Air Reports website. And the sheer undertaking and volume that it undertook to do those market assessments spanned a long period of time, and throw COVID and other things in there. The Secretary has discussed the need to update the data used during the market assessment, and our focus during the collaborative period with the Air Commission review process is to inject some new data that we have, and along the lines of COVID-19, in addition with the collaborative questions and feedback we get on the data quality move through the process.
Thank you very much for that. And then what would you say are the biggest lessons the VA has learned thus far with the chip-in pilot, and how are those lessons informing the VA's future plans with respect to facility-focused partnership efforts?
Yes, ma'am. And it's real. I'm really excited to talk about the Omaha chip-in project, and I'll hand off in a moment to Mr. McDivitt as that is in his career and his vision. We had a highly successful partnership there. They delivered that project on time, on cost, and it is reaping buckets full of awards since the day it's opened up. We garnered those lessons learned from that partnership and use them in real time. And I'll touch on just a moment a little bit on Tulsa, but we were able to take those lessons learned, and also our private team partners there, those lessons learned to transfer to Tulsa as well in the next project. One challenge we have is that the difference between the project types. We have lessons learned that we learned in Tulsa, which is a grand slam home run, but now we have a different project type in Tulsa. We're learning different lessons. What we do know for sure is we have demonstrated what the private sector and their construction methodologies can do to deliver on cost and on time. We absolutely need to replicate those in future partnerships, but also in our own major construction.
Thank you very much. I yield back my time.
Thank you, and now recognize the chairman of the full committee, Chairman Takano.
Thank you, Chair Allred. Dr. Brennan, I want to begin with you. When VA published its recommendations for the Air Commission, it did not provide an aggregate summary of those recommendations, which has made understanding them on a global level quite difficult. Based on my staff review, however, it appears that at least 40 individual recommendations touch on quote unquote strategic collaboration. And in these particular instances, VA isn't planning to simply outsource veterans care to community providers. So, Doctor, can you speak to how VA envisions leveraging strategic partnerships as it continues its future footprint?
Thank you, Chairman Takano. I'll start with the infrastructure aspects, and I'll ask Dr. McDivitt to talk about really the meat of those strategic collaborations, which is the healthcare collaboration. You know, a lot of them are listed as, partnerships with academic affiliates, DoD VA partnerships, And I mentioned earlier that though we have steering agreements where we currently do a lot of partnership sessions, but we don't have an infrastructure side where it's joint development with other private companies. DOD, we talked about Lovell a little bit earlier. That was a one-off driven by BRAC and CARES Act that brought that together. So we just received now 2022 NDAA authorization for joint DOD, VA planning, design, and construction. That's a new tool that we were able to use as we evaluate these recommendations to move forward for infrastructure solutions.
Okay, can I stop you there? It's difficult for me to, you're somehow kind of muffled, and I don't know what it is. The sound is not very clear.
Sorry, sir, is it better? I don't know if my headphones.
A little better. And then you were talking about the recent NDAA. There's some authorization of some kind, and you're moving forward with what?
Yeah, so in NDAA 2022 authorizes for the first time joint DOD VA planning, design, and construction. And so that authorization will now allow us to move forward with a new level of planning of DOD for some of those strategic collaborations that are recommended in air or anywhere else where it would be mutually beneficial to DO and DOD. But I'd like to ask Mr. McDivitt to talk about really the meat of those collaborations is the provision of the care benefits and services.
Thank you, Dr. Brennan, and thank you for the question, Chairman Tucano. In my own vision, Vision 23, we have a number of strategic collaborations that are recommended as part of the market assessment, including one in Congresswoman Miller Meek's district, which would essentially emulate what we have achieved with Common Spirit Health at the Omaha market, looking for a partner to establish a community living center or VA nursing home in eastern Iowa, where we haven't had a market presence so far. We also have, as you indicated, Chairman Tucano, proposed partnerships with academic affiliates in the Omaha market. We are looking to do a replacement bed tower, perhaps with an academic affiliate, perhaps using chip-in legislation as we move forward. And then we have some inpatient proposed collaborations in some of our smaller or medium-sized markets in South Dakota that would enhance our relationship with community providers and enhance the array of care that's available to veterans. And again, in every one of our markets, we will continue to have a strong VA presence.
Well, you know, and I understand the VA has partnerships with the Indian Health Service. Are you also enabled to work with F2HCs in certain rural areas?
We are, Chairman Tucano. We have not pursued that in our own vision, but that is certainly an option.
That's something I think, I know that Annie Custer authored legislation that would, I wasn't sure whether it made it into law or not. You know, my concern is that whether or not there are areas of the country where VA is pulling back, especially in rural areas, and where there are less providers. I mean, ironically, putting people into the community may be more viable in urban areas where there are more providers. But I don't know if it's tenable, the idea that we're only going to give veterans not really a choice. The community may be their only choice. Is that really what we want? Is my question. So my time has run out, and you don't have time to respond to it, but maybe that's something that you all can respond to me in writing about this idea of, like, in rural areas especially, you know, how do we deal with the fact that there's a low level of providers, and if we're closing down CBOCs or our presence, and the community is the only thing that's left, is that really truly a VA presence? So I yield back.
Thank you, Mr. Chairman. Now recognize Mr. Roy.
I thank the chair. Appreciate it. I appreciate the witnesses. Thanks for your time and appearing here before the committee. Obviously, we all, I think, on a bipartisan basis, share the desire to have a collaborative environment, have the VA be all that it can be for all of our veterans, moving in and out of the private sector of the VA and using collaborative environments where we can get the best infrastructure and the best facilities for our veterans. I do hope we'll continue to have community care conversations, be a continued focus on. I know today's about infrastructure. I know it's about facilities. I don't mean to suggest otherwise, but the entirety of the ability to, for our veterans to go get care wherever he or she needs that care, and to be able to use the facilities that are best for that and weave in and out of that system effectively is the goal. That's what I hear from veterans across the district in Central Texas. Obviously, we have a lot of veterans in and around San Antonio and Austin, and that's what I hear repeatedly. I hope we'll have more hearings on Cerner and on technology and all of the barriers that we know that exist on the free flow of veterans moving in and out of the private care and in and out of the VA. I do have just a couple of quick questions. First question, Dr. Brennan, I hope you can hear me. The VA's fiscal year 23 budget includes $5 million to support the Air Commission. Just real quick, how did the VA arrive at that dollar amount? And will it be the chair of the Air Commission, once confirmed, I suppose, who has the final say on how those dollars are spent?
Congressman Roy, can you hear me okay now?
I can, yeah, thanks.
Thank you. Yes, that was put into the budget, the division to provide support based on the chairman of the commission's requirements, and we would have some flexibility to provide administrative support for the commission.
Okay, and a quick follow-up, does the budget request assume that the commission would have been confirmed by the Senate by this point? And given that there's been a delay in the confirmation, does that change anything with respect to the expected investment in fiscal year 23?
I believe, Congressman Roy, that depending on the seating and if there's an extension to the commission's timeline, that may have an impact.
It may have an impact. Okay. Let me ask a little bit more open-ended question. Dr. Brennan, in your written testimony, you were talking about the VA strategies in the AIR report that talk about strategic collaboration in the 5 VISN 17 Texas market areas. I won't go through the various regions, but throughout Texas. Texas is big, so there's a lot of those places. And as the chair well knows. But I think that it reflects much of what Texas has to offer. Can you just elaborate a little bit on the kinds of partnerships the VA envisions in with respect to Texas in those 5 markets?
Yes, sir. And I believe.
And I realize it's a little specific, so you can follow up with us on that in more detail. But just you can give a quick answer, or just any particular vision for what you're doing for Texas.
Sir, we would have to follow up. So as we look at all the requirements and if it's in relation to any potential AIR recommendations, we would consider all of the tools that are offered to us to determine what may provide the best value solution and the quickest solution to put the right care in the right place at the right time.
Okay. It'd be great to have a little bit of a follow-up and specific understanding of how that relates to Texas. And one quick question, Mr. Murray, in the minute that I've got left. Can you talk a little bit about the importance of the Air Commission and what that means for future veterans? I just kind of want to get your perspective on that.
Absolutely, Congressman. We believe the Air Commission was rightfully asked for so that we right-size the VA to where the veterans are, as opposed to the BRAC process where DOD puts assets where it wants. The AIR process was supposed to put care where veterans are. If that's done correctly, we believe that will be beneficial for veterans.
Do you have a perspective, Mr. Murray, on the urgency of the Senate to confirm commissioners as soon as possible in order to, carry out their activities and their work?
Yes, sir. As General Bergman mentioned in his opening statement, urged the Senate to move that process along. We agree. We want to see, as he said, we believe this process is necessary to give a thorough review of VA's footprint, and that has to get started. Just talking about it isn't enough. We need to actually get down and get the work started.
Thanks, Mr. Murray. Thanks to the witnesses. Thank you, Chair.
I thank the gentleman. Now recognize Ms. Underwood for 5 minutes.
Thank you, Mr. Chairman. Today's conversation about strategic partnerships at VA includes an example from my state of Illinois, the Captain James A. Lovell Federal Healthcare Center in North Chicago, which serves both veterans and active duty service members, and is the first ever integrated healthcare center between VA and the Department of Defense with a unified governance structure, workforce, and budget. According to a 2017 Government Accountability Office report, the Lovell Demonstration Project has not produced clear facilities benefits and faced cost challenges. Based on these findings, VA and DoD have been carrying out cost effectiveness analyses to reduce project costs moving forward. Mr. McDivitt, in addition to looking at overall costs, what other metrics is VA using to evaluate the Lovell Demonstration Project, such as patient satisfaction, wait times, and other indicators of healthcare access, quality, and outcomes?
Thank you, Congresswoman. The Lovell facility is in my neighboring vision, in Vision 12. I will have to take that question for the record and get back with you. I would say, we are constantly evaluating our partnerships. We're doing the same with our partnership in terms of Omaha with the Ambulatory Care Center and our emerging partnership with Catholic Health International for a long-term care center.
Although much of today's conversation has focused on addressing physical infrastructure challenges at VA, the fundamental goal that we've been working towards is ensuring that veterans in every community have access to high quality care, a goal that cannot be achieved without a high quality workforce. In February of 2022, Secretary McDonough released his human infrastructure plan for VA. The very first point was passing my VA nurse and physician Assistant RAISE Act, which was bipartisan legislation that was enacted as part of the fiscal year 2022 government funding package, and it will allow the VA to offer competitive salaries to recruit and retain the healthcare workforce that the department needs to ensure our veterans have access to timely, high-quality care. But the VA is still facing severe workforce shortages, including in anesthesiology, that predated the COVID-19 pandemic and have been exacerbated by the pandemic, resulting in an April 2020 directive from VA urging medical facilities to use certified registered nurse anesthetists and other healthcare professionals to the full scope of their licenses. Now VA is carrying out a review to determine whether the department should expand full practice authority to CRNAs on a permanent basis, which would bring VA policy in line with TRICARE and the majority of states, and it's supported by leading VSOs. A comprehensive assessment of the clinical effects of granting full practice authority to CRNAs found no patient risks when CRNAs practice without physician supervision. Mr. McDivitt, given the absence of any scientific or clinical argument for restricting CRNAs from practicing to the full extent of their education and training, can you describe what other considerations would be relevant to a VA determination on CRNA practice authority?
And thank you for the question, Congresswoman. And thank you for support of the RAISE Act. We have really endeavored to recruit and retain staff across our vision in a very challenging recruitment market. We're using recruitment and retention incentives, special salary rates wherever we can, holding hiring fairs, holding onboarding fairs to assure that we provide the finest level of support for staff. In terms of certified registered nurse anesthetists, they are a key part of our staff, have been for a long time. We really value their practice. That's being reviewed, as you indicated, under the National Practice Authority process that is moving forward. And we are certainly endeavoring to make sure that we recruit and retain every CRNA across our vision, and that we understand the value that they provide to VA while this.
Sure. My question, sir, was about the key considerations that would be relevant to the VA determination on the CRNA practice authority. Are you able to speak to that?
Yeah, I'll have to take that for the record, Congresswoman, and work with our central office team to respond.
Given Secretary McDonough's commitment to following the science, which is a guiding principle for the Biden-Harris administration, it's imperative that VA follow the evidence and move swiftly to grant CRNAs full practice authority at the department. Our veterans deserve access to excellent care, and the data clearly shows that CRNAs provide high-quality care that our veterans need, there is no justification for any further delay. Thank you, Mr. Chairman, and thank you to our witnesses. I yield back.
I thank the gentlelady and recognize Ms. Radewagen for 5 minutes.
Talofa. Thank you, Chairman Allred and Ranking Member General Bergman, for holding this hearing. Thank you, of course, to the panel for your testimony. Dr. Brennan, what factors influence VA's decision-making about whether or not to pursue facility-focused partnerships with the private sector or with other government entities?
Ma'am, thank you for that question. First off, it's a valid requirement demand signal from the operational mission that's entered into our capital program request and decision model to determine what the requirements are. And then it's a matter of looking at what are all the potential options that are out there that can best meet that requirement, whether it be our major leasing or minor leasing program, our major construction, or these innovative partnerships. The genesis of the partnerships really is community-based and percolates up through our local directors at our facilities out there and through network directors like Mr. McDivitt. And then we can match the requirements and the potential options we have with all the authorities we have to deliver the best value solution based on a business case and what delivers the infrastructure to provide the care, benefits, and services in the most timely manner.
So, Dr. Brennan, other than the project already underway in Oklahoma, how many other potential chip-in pilot projects is VA considering currently, and where are those projects located? And I do have a follow-up question as well. Maybe I should ask that and you can crank it all in. Are there any other locations across country where VA is considering acquiring a facility similar to the one VA acquired in Garland? And is VA specifically looking for opportunities like that one? Why or why not?
Thanks for the question, Congresswoman. First, with the chip-in is we have started with a second partnership with a private group in Tulsa, Oklahoma, and that is in the early planning stages and underway. It's a much different project than the highly successful clinic project in Omaha. We have 3 remaining pilot authorizations that has been extended for 5 years through 2026. That there are some initial discussions in various communities and that have been introduced with the local VA leadership. Also in the secretary and his travels, he has received some inquiries from people who are interested in the program. That success in Omaha is really building some buzz and some momentum where we're starting to get people are more aware, reach out to that. We have not identified those agreements or partnerships for the 3 remaining yet, but we hope to do so within our extended authorization period. In regards to property transfers like the one in Garland, Texas, DHA recently put a request, acting Undersecretary Dr. Lieberman, a request in Norman, Oklahoma that the consideration is approved. That's in the early stages. And once again, to my earlier comments, this is to fill a gap. It's an older facility, but it's going to help the VA put the right care in the right place at the right time while we continue to develop our other long-term strategies and options.
Thanks, I'm running out of time. Dr. Latham, given what GAO has found in its work thus far regarding the joint VA-DoD facility in North Chicago, do you think that Congress and VA should consider establishing more joint VA-DoD facilities? Why or why not?
Thank you for the question. Well, we certainly reported many lessons learned from the Level Health Project. Of course, as we noted, this is an unprecedented integration, looking at having a single line of governance, also a single line of funding, and joint workforces. We, as you know, recommended that they do cost-effectiveness analysis, which they are still continuing to do. They have reports through 2021, and the departments have not come to a conclusion as to whether or not they would do the overall sort of success, could determine the success of this implementation. But I think we would sort of say it, it remains unclear whether or not this duplication of this effort is warranted. But certainly some lessons learned for moving forward in terms of the unprecedented nature of the arrangement.
Thank you, Mr. Chairman. I yield.
The gentlelady, I recognize Mr. Rosendale.
Thank you, Mr. Chair. Dr. Latham, thank you so much for joining us today. I appreciate your testimony. What specialized or standard services are these new facilities that we're talking about providing that are not already available in those communities through other healthcare providers that are located there?
Well, is one of the, you're speaking of the chip-in projects? The one chip-in project provided an ambulatory care center, and another chip-in project provided inpatient hospital services. And both of those areas, though, provided services expanding to more veterans to the care. In terms of what additional pieces of that, we'd have to look into that further, get back to you on it.
So what I'm trying to determine is, are those types of services already available in those communities through other healthcare providers, is really what I'm trying to drill into.
That I don't specifically know, but I do know that these facilities certainly expanded the care and access to the veterans for VA facilities in terms of the outside community.
I understand that, but I'm just trying to determine if we've got a duplication of efforts and try to make sure that we're using the dollars as wisely as we possibly can. Dr. Brennan, is that something that you might have information on that you could tell us? Is if we have a duplication of efforts, are some of these services already being provided in those communities?
Sir, I'll give my best effort from the infrastructure point of view, and then ask Mr. McDivitt to comment on that. In Omaha, it is a new facility on the campus of the VA Medical Center. It is complementary. I'll let Mr. McDivitt talk about that. In Tulsa, it's bringing inpatient care to a medical campus in partnership with Oklahoma State University downtown, and that brings inpatient care, VA inpatient care, to an area where it currently does not exist.
Okay. Dr. Latham, given what the GAO has found in its work on the joint VA-DOD facility in North Chicago, do you think that Congress and VA should consider establishing more of these joint facilities?
Well, as I was saying earlier with the results, it does remain unclear. I mean, they looked at, with their cost-effectiveness analysis, they looked at the total cost per patient, they looked at outpatient cost per patient, they looked at inpatient beds, they looked at the full-time equivalent of employees per patient, and they looked at the value-cost ratio comparisons. So did an in-depth analysis, but again, the results are still unclear, and it remains to be seen. But certainly some lessons learned to move forward.
Do you believe that there were factors, or what do you believe were the factors that were preventing the cost savings and efficiencies at the facility?
We talked about that in our report. Some of the issues that came through were integrating the information technology. It was delayed, it took a long amount of time. There were many levels to that and many challenges. There were also some staffing challenges as well. I mean, coming to join those two workforces together and coming up with a staffing plan to determine what's most efficient. So those are some of the, I would say, some of the contributing factors to the rising costs that even VA noted as well, and DOD.
And that's the kinds of things that I'm trying to get at. If we're competing with withdrawing staff, opportunities and availabilities, okay, everything is about supply and demand from the community, when we already might have a facility there, that we would be better off investing in the health care for our veterans in a different way. That's what I'm trying to get at. Mr. Murray, like I think everyone in this room, and yours, my focus is on making sure that we deliver health care where and when our veterans need it. The whole focus should be on the veteran, as far as I'm concerned, not the Veterans Administration. It should be on the veteran. That's where we should be focused. Some of the AIR recommendations could very well leave veterans in eastern Montana, which is extremely rural. We're talking frontier, hundreds of miles from their nearest clinic. It's expensive to keep a facility open that's made to serve a small portion of an already small community. And I get that, and I don't begrudge the VA for divesting some of those facilities. Again, I understand dollars and cents and investments. Do you believe that community care networks in those places can play an important role in places that we have to make those types of decisions?
Congressman, community care is VA care. We believe it is an essential supplement to VA care. However, we still want to see VA as the main driver. We want to see VA as the primary care deliverer, but we also understand there might be areas, and I'd have to go back and take a look at the Montana assessments. I know there's some different discrepancies in there, but in terms of what might be best for community care, could be that could be a region where that might be the best option for veterans. It is something that is on the table, and we think we need to make sure that all the numbers match up so that we can properly say, in your area, community care might be best, or it might be a VA clinic. I'd have to take a look at that one specifically to give you a better answer, though.
Thank you. Mr. Chair, I see I've gone over. I would yield back.
I think the gentleman recognized Mr. Elsey for 5 minutes.
Thank you, Mr. Chairman. Thank you to all the witnesses who are joining us here today. You know, I often say that the VA has a job that is impossible to ever completely accomplish because you can't reach out to every veteran over time, although that is the mission. So what concerns me about this is effectively we have a BRAC commission for these facilities, of which there are 145 hospitals, 134 community living centers, 5,646 total buildings, 16,000 acres of land, and 20 million square feet of space. They're very old. We have, and they're all trying to reach out to a veteran demographic that has shifted throughout our nation since they were built. So it's extremely important. And since this law came into effect, we're waiting on a commission to be appointed. The commission hasn't even been appointed yet. Mr. Murray, do you know how many commissioners of the 9 have been appointed so far by the president?
I believe there's one left to be appointed, and then the confirmation hearing needs to be scheduled.
Okay. So if this by law, we should have 9 commissioners appointed by now. They haven't been. And until then, they can't be confirmed by the Senate. So until they're confirmed by the Senate, they can't start their work. And a lot of people have poured a lot of work into it, into this AIR Commission, and the VA has spent a lot of time identifying which buildings they need to realign, rebuild. We are a beneficiary in Waxahachie, Texas, of a new clinic. 1.7 million veterans live in the state of Texas out of 30 million. We've got the highest number of veterans in the state of Texas. What troubles me here is that by law, we've got 8.5 months until this whole thing is wrapped up or it completely goes away. So we spend a lot of time talking about what facilities should be open or closed yet, but by law, the president hasn't done his job. He's supposed to execute this. He needs to appoint somebody now, because otherwise, the veterans of this nation, once again, are going to be left on the trash heap when unfairly they need to be getting the attention they should get. So I don't know if somebody's intentionally dragging their feet, but just so everybody knows what the timeline is, once the commission is seated, they have to make their recommendations by January 31st, 2022. And then the president can look at it, January 31st, 2023, and then he has to decide if he's good with it by February 15th. And then by March 30th, the commission comes back to him with if they have any changes. And then once the president approves of those recommendations, Congress has 45 days to do it. So we're at 8.5 months right now to talk about all of these hospitals, all these facilities. It's almost an impossible job to do. So I really don't have any specific questions for anybody, but because most of this stuff is out of y'all's hands. But until the president does his job, and then the Senate does their job, we can't do what's right for the veterans of the United States. And I'm tired of talking about doing what's right for the veterans of the United States. So I call on the president to make your final appointment. And by the way, I'm in a rural district. We need some rural representation on that commission. There's no rural representation. And like Mr. Rosendale said, you got these veterans off in remote areas who need help of some kind. give them the attention they deserve, because I know a lot of veterans who, once they're done with their service in the military, they just want to go spend time by themselves, but they deserve to be taken care of. They live out on farms. They live out in remote areas. We owe it to them to do what's right by this commission, get it taken care of, and make these recommendations, because this job is far too big to be accomplished in 8.5 months as it is right now, and we're getting no indication. So I'd like to find out from somebody. I'd like the Congress to hear from the President when he's going to appoint this final commissioner, and ask our colleagues on the other side of the building when they're going to do their job and get this process started. So I thank all of you for your hard work. I hope it doesn't go to waste, because if it does, they're going to hear from everybody sitting up here today in a very unpleasant manner. So thank you all for being here. I yield back my time.
Gentleman yields. Recognize General Bergman for however much time he will consume.
Thank you, Mr. Chairman, and I'll try to make it productive for all concerned, because number one, when we have a hearing like this, I believe we're all focused on doing the right thing for the veterans. The question becomes, what is the right thing? What are the priorities of the right thing, so we can actually get it done? So, Mr. Murray, I know that the VA was and continues to be a supporter, the VFW. I think I said VA. The VFW, and continues to be a supporter of the AIR Act. Why do you think AIR is important for veterans and for the long-term success and sustainability of the VA healthcare system? And what do you think that veterans and the VA would lose if the AIR process were not to move forward?
General, we fully supported the establishment of the AIR Commission. We believe that a fair and honest assessment needs to be done of VA's overall footprint. What veterans would lose is the ability in areas where we need to grow and expand and shift VA care toward them. For example, in North Carolina right now, there is a facility in Raleigh-Durham, and it's there because of a partnership with Duke Medical. But the veterans are near Lejeune. So VA needs to look at where to properly leverage that partnership with Duke Medical, but also put the care where the veterans are. That's the kind of example that we think could come out of the AIR Commission, along with great partnerships that we've had for years.
Okay. And to kind of follow on there, if for whatever reason AIR were not to move forward because a commission is never confirmed by the Senate or for some other reason, what is your confidence level that the status quo in which the VA assesses and mitigates infrastructure issues, that how they're currently addressing them in kind of a piecemeal fashion through the SCIP or funded through the regular budget process, is the current way of doing business without an error sufficient to fix problems that the VA has when it comes to the existing infrastructure?
So first, I recognize Mr. Elzey's concerns about the commission not being appointed, and I will use this opportunity to ask Speaker Pelosi, Leader McCarthy, Senator Schumer, and McConnell to all send in their nominees ASAP to get that process going to the President to then name that commission. But status quo is not good enough. We do believe, though, that the AIR Commission and reforms to the current process can be done on parallel tracks. The AIR Commission can proceed, and we also need to do a better job of resourcing VA infrastructure. If we look at the rest of the country, infrastructure is a problem. VA is no different. We need to do a better job so that things like the AIR Commission aren't necessary to replace 60-year-old buildings.
So, and kind of piggybacking on Mr. Elzey's comments, would you support, let's say, timelines are timelines, would you support extending, say we get the AIR Commission confirmed, would you support extending the timeline to ensure that the commissioners have a full year to do their work once they are confirmed?
We'd have to take a look at that. I think at this point, all options need to be on the table. This is a large process. our staff, I've personally only gone through 4 visits myself and nowhere near to the level that the commissioners need to. It's going to take them a long time. They also need to hold hearings around the country to hear from veterans. That's going to take a long time. We want to make sure that this is not some kind of half-baked endeavor.
Okay, thank you. Dr. Brennan, what would you say to those who fear that the data VA used to make recommendations to the Air Commission is faulty because it was collected during the pandemic? And does VA have any current plans to update or refine market assessments to verify the data, regardless, you know, when it was collected? Is the data accurate for the commission to consider and make recommendations on?
Yes, sir. And the secretary has recognized and discussed that the VAs need to update the market assessments as we work through collaborating with the commission as they do their work. And additionally, as we do additional infrastructure analysis to operationalize, to actually plan the strategy and execution for the recommendations, we have another opportunity to look at the lessons learned, particularly the infrastructure that we've learned during the COVID pandemic with things such as air changes and how to handle the contagious environment and how VHA worked miracles coming up with solutions to protect veterans. We've been gathering those lessons learned and are prepared to inject those into the capital programs as we move forward.
Okay, and again, Dr. Brennan, continuing to go forward with lessons learned, because we've had, you know, the chip-in pilot program. Would VA support expanding the chip-in pilot and or making it permanent? And if yes, why? And if not, why not?
Sir, I'm not in a position to speak for the secretary on that right now, but what I can say in my professional opinion as the chief facilities person for the secretary, the program is demonstrating great success. My recommendation to the department would be that we should absolutely continue the success. What we have to find out now as we do different types of chip-ins, what new lessons or challenges that we may have that may require some tweaking to the authorization, the language of the legislative authority right now. I'll use one example of that. So currently, when we enter our agreements, we lock into what our contribution as the VA is. That worked out perfectly in Omaha. We'll see how this works in Tulsa because we're in an entirely different economic environment where many external pressures coming together may stress our partners and their ability to raise money while we're constricted and locked into what our original agreement was. We'll work through that and find out what the impacts and what recommendations may come out. But I just use that as an example that these pilots are going to flesh out some more things that may inform some adjustments.
Okay, and Mr. McDivitt, would you care to comment on the value of same questions I asked Dr. Brennan about expanding the chip-in and potentially making it permanent? Because we know for a fact that the setup of the VA, you've got VA, headquarters here in DC, you've got your VISN headquarters around the country, and all VISNs are not created equal from the standpoint of you have the latitude to take the geography, the AOR, if you will, in which you operate and make the right decisions. So do you have any comments on, on chip-in or that sort of program to enable you as the person who runs that VISN to be able to maximize what's available to you in the geography of the Midwest where you are?
Sure. Thank you, General Bergman. And it's nice to see you. We had the opportunity to work together when I was in Ann Arbor for 9 years, so appreciate that. In terms of the chip-in legislation, as you heard from others, the partnership in Omaha was very successful, working with tremendous community partners like Walter Scott, with a corporation that helped us to manage a project and complete it 4 months ahead of schedule and within budget, to provide veteran-centered services, new women's veterans clinic, surgery service, specialty care services that we were providing in Omaha, but in 1950s vintage space, and really to dramatically improve care for Omaha area veterans. We are looking for similar partnerships across the vision, and we'll continue to do that. One of the benefits of our significant involvement with communities during the pandemic has been that our medical center directors and me as a vision director, to a lesser extent, are sitting on incident command centers for community hospital associations and so on every day, assessing the impact of the virus and the pandemic and how we can work together to do that. And we certainly intend to try to leverage those relationships to identify additional partners within our own vision. And I know my colleagues across the country are doing the same.
Okay, thank you. And I'm going to go down a different road here just for a minute, and I want, if you will, all of you who have taken the time to testify today to, if you will, take this one for the record. If you will, don't expect comment from you now, because it would not be fair to you all to ask you a question where you haven't had the chance to think about it on the front end. But as we look at the partnerships, I would like to hear from the VA at whatever level, and also from the VSOs. And the subject is utilization of excess space that is available in tribal health clinics. In my first district of Michigan, we have 8 tribes. And as we know, there's a significant percentage of participation in the military by tribal members. They are absolutely spectacularly great Americans, and they're going to get their health care in some form or fashion, but we right now, at least in our district, have excess space that we could be providing a different form of care in the community that serves not only the tribe, but also members, those veterans within the local area, that is a balance between the sovereign nature of the tribe and what the VA is trying to deliver. So I would like to basically kind of put that marker out there to hear responses from all of you at all levels, to include GAO and everybody else, as to how we take, and by the way, I've seen it. I've been in the clinics to see the empty rooms that are not being utilized but could be. So we're not talking about building new space. We're not even talking about renovating space. We're talking about utilizing existing excess space. So with that, Mr. Chairman, I appreciate the extra time, and thank you, and I yield back.
Well, thank you, General Bergman. I appreciate your focus on trying to find creative ways to expand space. That's certainly what we're trying to do in Texas as well. I do want to just point out, just so that we're all clear, that in terms of the appointments to the Air Commission, it is Senate Leader McConnell's a pick that is still the one that is lagging and has not been submitted. So in terms of where we're going and how we get that done, we all want to see that done as quickly as possible, and to see these folks help us review this. I want to thank each of our witnesses for their participation in today's hearing. Your testimony and your comments have been enlightening, and we certainly take them into account as we consider future opportunities for VA to partner with other entities to improve its infrastructure and capacity to deliver health care to veterans. All of our members, I think, have taken a lot of interest in this, and we appreciate your testimony. And with that, the subcommittee stands adjourned. How should I say that?
Thanks, everyone.